Yeah, I think that's an interesting question. We always say, oh, we can't compare across trials, and then we all put up a table comparing all of them. I think we need that. We need to have them side by side to see what the response rates are. Like I said, exciting times. We've had a plethora of these new drug treatments come online recently, and so. Is one better than the other? We don't know. We're hitting what we know, the target that used to be in the 20-30% range has moved up now to the 60 to 70% range. So that's sort of the new target for complete response at any time. The real question is durability of the response. Are these going to be durable? And how are we going to sequence this? There's no question we're going to be sequencing these in the future. Now, there are advantages and disadvantages of each of the treatments. Some treatments, Adstiladrin is once a quarter, as one single installation. That's a huge advantage for patients who are traveling far, who can't come in, have right issues. The TAR-200 is placed once every 3 weeks, at least for the first quarter, and then after that, it's done once every quarter. So there's that advantage of having drug available to the patient with very high initial CR rates, but there's a disadvantage of the in and out. It's very well tolerated, so I think a lot of patients on the trial currently are happy with this. Then you have the traditional intravesical treatments. You have the doublet gemcitabine docetaxel, which does work very well in patients. We've got almost a 50% 2-year recurrence-free survival in these patients. It's a doublet. It's twice the time it takes for the BCG. It's fairly well tolerated, and so each one I think is unique in its delivery and its duration, tolerability. In terms of side effects, again, I think we've increased the bar for CR rates, and we've really, lowered the floor for tolerability of side effects for medications, right? Because these new medications are really, all of them across the board are well tolerated. So that's exciting too. So that means that in the future we can sort of think about these carefully and be able to sequence them, say, okay, we're going to try this first, then this, depending on the patient's needs. But in terms of what do we pick first, I don't think we have an answer. We may in the future. What's better, one or the other. There are going to be very few head-to-head trials with these drugs. They're expensive trials. It's tough to do. But I think as we gain more experience in the real world, we're going to be able to at least make some sense of what we should do in the first. We'll have options, obviously. What we should do in the beginning, and then what makes sense in sequencing. Yeah, I think that's there from the very beginning. I think those discussions of quality of life and how it's administered. Now, everybody's going to be BCG unresponsive in this space for the most part. And so they have experienced the intravesical treatments and the once a week and the catheters and installation. The ones who've had significant voiding symptoms, the ones who are having a terrible time with BCG, their bladder looks super inflamed, those are the ones we're going to think about. Maybe one therapy may be better than the other because it doesn't cause as much irritation, or we don't need to go in and out as often. Something like Adstiladrin might make better sense for that patient as a single installation. Someone who can't tolerate two separate chemo agents in there that can't hold the medication for too long is not an ideal candidate for gemcitabine docetaxel. Someone who's had gemcitabine in the past, recent past, the addition of docetaxel I'm not sure makes sense for that patient, for instance. So there's these nuances I think we're going to use. But quality of life, back to your question, is very, very important. I think our job in the future will be to describe these new novel medications to the patients and let them know, what the schedule is. I think schedule is very important and ties into this quality of life, and have the patients sort of choose, give them what we know about the CR rates at 1 year, 2 years, and say, look, this works well, the other one works better, but has these other, things associated with it, and have them choose. We're kind of doing that a little bit right now with multiple clinical trials open for the same space, and patients are sort of saying, okay, I'd like to, sign up for that clinical trial. But at the same time, I think, putting it too much on the patient also, it's our job to guide patients. Many are overwhelmed with all this information and what works better. These things that roll off our tongue, the CR rates and durability of response and things like that is difficult, some concepts sometimes to understand for patients. So I think it is our job to guide patients, and we're going to have biases ourselves, as we do in every space, right? In prostate cancer, we have a plethora of medications to use now for locally advanced and advanced disease. So I think our job is to make sure we know everything we know about these drugs in the future so we can guide the patients better.